section of the emergency medicine revision series. So this is aiming to help you with your acute care block and your upcoming exams. We did poisonings and overdose yesterday, and today we'll be doing some acute arrhythmias. I was a HIMSS grad a couple of years ago, so I'm used to the HIMSS exams and the type of things they like to ask. So yeah, this is the revision series. We're here on the acute arrhythmias one, and then this is what we've got coming up over the next sort of month or so. So this won't be an overly long session. We're not going to cover a great deal because I don't want it to be too complex. I'd rather just make it sort of more exam focused. So we'll be looking at the bradycardia algorithm, the tachycardia algorithm, and then some common arrhythmias that come up in exams all of the time. We won't be doing the long-term management of arrhythmias such as atrial fibrillation and the Chad-Vasc stuff. It's not really in the scope of the acute arrhythmias, so that will be covered obviously elsewhere as part of your own revision. And obviously we're not going to cover every single arrhythmia that you're going to come across in exams and in clinical practice, but I've tried to pick out the important ones that tend to come up quite a lot. Just very briefly, the ECG, you will all know this, the morphology of the ECG and the ECG strip. With your PR interval and segment, your QRS complex and your ST segment with your T wave. So I'm not going to bore you with the ins and outs of it. Cardiac axis is something that people tend to get wrong and get a little bit confused about. You can complicate it, but this on the screen is a very brief, good little snapshot of how to work out the cardiac axis. Essentially, the cardiac axis is the average of the electrical activity, which direction it's going in. So if you've got left axis deviation, the electrical activity will generally, over an average, be more left. And obviously the right is the opposite. The way you can distinguish it is if you look at leads 1 and 2, or 1 and ABF, if they point away from each other, the QRS complexes point away, then that's left axis deviation. If they point towards each other, then it's right axis deviation. You can go into a little bit more detail about the ins and outs of it, but generally it's a good way of remembering the cardiac axis. So some common arrhythmias we'll go through first, and then we'll look at the bradycardia tachycardia algorithms. Any thoughts on a diagnosis with this ECG? So we're going to need a bit of audience participation for some of the ECGs. You can comment in the chat, and Carolina, can you just see what people have bobbed in?
Yeah, no problem.
All right.
So Charlotte has said first degree AV.
Brill. Yes, it is first degree AV block. First degree AV block is where you just get prolongation of the PR interval. So you can see that it's slightly longer than the 3 small squares that it should be. This is about 5 small squares. So yeah, first degree AV block. With this, we do absolutely nothing generally. It doesn't usually cause many problems. It's normal in a lot of people, so we don't do anything with it at all. This one.
Is this Mobitz 1?
It is Mobitz 1, yes. Why is it Mobitz 1?
And Paulina has said the same thing. Does anyone want to explain? It's progressive PR and then drop by Charlotte.
Yes, progressive PR elongation, then the drop. So you can see here, this is the PR interval. Here it's slightly longer. Here it's longer again. And then you can see on this one, there's a P wave, but there's no QRS complex. So this is the Mobitz type 1 or the Wenckebach phenomenon. Again, this is a reasonably benign condition, usually by sort of just progressive tiring, essentially, of the AV node. We again don't tend to do a great deal with these because they're usually quite stable. What about this one?
Charlotte has said, is age relevant for second degree type 1?
What was the question, sorry?
Is age relevant for second degree type 1?
Yes, it is. There's lots of other factors that are relevant for type 1. Depends on what the potential cause of it is. As we'll touch on later, you can have an acute cause of a Mobitz type 1. As you get older, the AV node and the electrical system tends to tire and you get more fibrosis. So there's more likely that it's going to progress to the more serious types of block and that you will need to do something about it. In an acute phase, Mobitz 1 doesn't tend to be too bad. You don't tend to get too much sort of severe bradycardia and severe low blood pressure. But you're right, as you get older, there's more likely that it's going to progress to a more serious type of block. So yeah, age, I suppose, does play a role.
And Charlotte has mentioned ventricular ectopics or idioventricular.
Yep, so they do look a little bit like ventricular ectopics. Yes, I agree. Sort of an escape rhythm. This is demonstrating Mobitz 2. These are broader QRS complexes, I agree. So you've got 1, 2, 3 and a bit squares. So probably just about narrow, you can argue. So this is Mobitz 2. You can see that there's the P wave here, followed by a QRS complex, a P wave, then a QRS complex, and then a P wave and nothing. So this is Mobitz 2, because you can see there's actually still an association with the P wave and QRS complex, which is different to the one on the next screen. Just a little bit about Mobitz, the Mobitz 2. This is slightly more serious than the Mobitz 1 because it's more likely that there's actual damage to the conducting system. There might not be a pattern to them, but often it's in a 2-to-1, 3-to-1 type pattern. So here, you could probably argue that this is a little bit more sporadic because you've got two P waves that haven't conducted a QRS complex. Generally, you will see it as a 2-to-1 block or a 3-to-1 block, where you'll have 2 QRS complexes, 1 dropped, then another 2 QRS complexes with 1 dropped. This is associated with a really severe bradycardia and quite a quick progression to third degree block. And with that, you've got around just over a third risk of asystole. So these will always require a pacemaker if you see that. This is complete heart block. So the final one of the AV blocks, essentially. You can see in the ECG, if you look at the rhythm strip at the bottom, there isn't really an association with the P waves and the QRS complexes. The QRS complexes look a little bit more broad because they're coming from the ventricles themselves as an escape rhythm rather than a true rhythm caused by contraction of the bundle of His. You can see sort of there's a P wave here, one there, one in there as well. In there, so there's no association whatsoever. There's no pattern to it. It's completely random with the escape beats. This is a very, very serious rhythm, and if you see it, the patient is impending asystole and impending cardiac arrest. So it needs to be treated quite quickly. Inevitably, these patients will need a pacemaker. Yeah, as we mentioned. So does anyone want to tell me just what this ECG is showing and why is it showing that? talk me through the ECG.
Charlotte has mentioned ST elevation or high takeoff.
Yes, there is ST elevation. What's the diagnosis from the ST elevation? What would you say is showing on the ECG?
Just from myself, would that be an inferior STEMI?
It would be an inferior STEMI, yeah. You can see that there's ST elevation in the sort of inferior lateral leads, 2, 3, and AVF. Why is that happening? Because there's also complete heart block here as well, hence why it's on the slide. So you've got complete heart block and an inferior MI. So why are those two together? Why are they both happening at the same time?
So Ravi has mentioned that it's right coronary supplies AV node.
Perfect. Yes, absolutely. Yeah, your right coronary artery supplies your atrioventricular node. So if you've got an inferior MI, particularly a big proximal inferior MI, it can cause ischemia to the node and cause any type of block really, but this one's showing a complete heart block. So very, very severe. This patient's more than likely going to be very, very poorly. What's the diagnosis in this one? So this is. Go on, sorry,
Charlotte, sorry, literally Charlotte just finished typing and she says anterior ST elevation.
Okay, so this is left bundle branch block, and I'll go on to why there isn't ST elevation here in a second. So left bundle branch block, you'll see in the textbooks is this W and M thing. So in V1 it looks like a W, and in M the QRS complex looks like an M. You get this small S wave. Small R wave followed by a really big S wave in the anterior leads, and sort of the opposite in the lateral leads. You mentioned the ST elevation, and you're right. Left bundle branch block does tend to have a little bit of ST elevation. So if you look at this picture in the bottom bottom left-hand corner here, in left bundle branch block, you need to have what we call dicordant changes, which means that if you've got abnormal depolarization, which is what the QRS complex is, this broad QRS complex, that's abnormal depolarization, you will have abnormal repolarization, which means that you will get this as the QRS complex goes upwards. That means that you will inevitably have some ST depression. And as the QRS complex points downwards, you will inevitably have some ST elevation because of this dicordance. So to distinguish between whether there is just left bundle branch block or whether there's left bundle branch block in the context of ischemia, so if you've got a STEMI as well, you can use this modified Scarboza criteria. And this looks at any of these three things being present. So if you've got concordant ST elevation, so if your QRS complex is pointing upwards and you also have ST elevation of greater than 1 millimeter, then that signifies that there's probably a STEMI. So if you look in this one, if you look at the where the QRS complexes are pointing upwards, you can see that the ST is depressed. So that's your dicordants. They're going in the opposite direction. Whereas in this one, they're going in the same direction. So that would signify there's potentially a STEMI on top of the left bundle branch block. The same with the depression. If you've got a downward facing QRS complex, if you then get ST depression, that again signifies a STEMI. Or if you've got ST elevation that's taking up greater than 25% in any of the leads, then that is signifies a STEMI. Important to note in the context of chest pain, a new left bundle branch block, regardless of the Scarbosa criteria, should be treated as a STEMI. So that's sort of a little nuance to the Scarbosa criteria. Has anyone got any questions about the Scarbosa criteria before we move on? Because I appreciate it's a little bit confusing. Okay, right, we'll move on then. But if there is any questions, please just shout them out, and I'm happy to answer them. In contrast to the left bundle branch block, you've got the right bundle branch block. Essentially, it's the same concept, but in the opposite direction. So the block is on the right-hand side of the conducting system, which means that the impulse then travels over to the from the left to the right. You get this RSR pattern in V1 and 3. Looks like bunny rabbit ears. That's the classic description of them. And this wide S wave in the lateral leads as well. So in this one, what would be the diagnosis? Any thoughts?
Charlotte's typing something, so I'll give it another minute.
Yep.
She said it looks like Brugada in V1, but I am overthinking
it. I think you probably are overthinking. It's not quite Brugada. So Brugada, you're right with the T wave inversion. You get with Brugada ST elevation in leads V1 to V3, followed by a scooped ST depression. So it's with a sort of right bundle branch block pattern. So it's not quite Brugada, but I could see where you were going. This is bifascicular block. So here you've got a right bundle branch block type pattern. You can see the sort of bunny rabbit type ears with a left axis deviation. So you can see that V1 and AVF and 3 are pointing away from each other, which implies that there is a left axis deviation. So if you think back to your anatomy of the conductive system of the heart, you've got your atrioventricular node, which then goes into the bundle of His and then splits off into your left and right bundle branches. So the right bundle branch is one entity, and the left bundle branch is split into two. You've got the left anterior fascicular branch and the left posterior fascicular branch. So with bifascicular block, this means that there is a block on the right bundle branch and one of the stems of the left-hand conducting system. So either the left anterior fascicular block or the left posterior fascicular block. You will get left axis deviation if the block is on the anterior bit of the left side. If the block is on the posterior, so your left posterior vesicular block, you will get a right axis deviation. Whether I've got one. Yes, so this is the other one of the bivesicular blocks. You can see here you've got right axis deviation with leads 1 and AVF and 2 pointing towards each other with a right bundle branch block pattern. So this is bivesicular block with the other bit of the block on the posterior aspect of the left side. Again, very easily examinable, and it's quite niche. So it's quite a high fidelity question if that does come up. Anyone want to give this one a crack? So this ECG is trifascicular block. So this is the next step up. So you can see you've got a little bit of a right bundle branch block pattern. It's not incredibly obvious, but you can see the bunny rabbit type ears here. And here where you've got a small S wave followed by, sorry, a small R wave followed by a smaller S wave followed by a slightly bigger R wave. So right bundle branch block, you've got this left anterior fascicular block again, because you've got this blockage of the anterior side of the left side of the conducting system, and you've got complete heart block with the P waves you can see on the rhythm strip at the bottom have got no correlation with the QRS complexes whatsoever. So this, again, very, very severe. The patient's more than likely going to be unstable with this type of ECG because most of their conducting system is blocked. Anyone want to give this one a crack?
Is it AF?
AF's a good shout. It's not AF. I can see why you've said that though.
And then Ruby said atrial flutter.
It is flutter, yes. I've been a little bit mean with this one because it's atrial flutter with a variable block, which does look a little bit like AF with some very subtle differences. So if you cast your eyes to the rhythm strip at the bottom, you can see that there is actually some sort of regularity to it. You can see here, you can count 1, 2, 3, 4 QRS complexes, followed by non-conduction. So this is your, essentially it's an AV block. And then you get 1, 2 conducted, followed by 1, 2 missed, and then another 2 missed. So that you can see that there's sort of a pattern to it. And this is a variable block. Often you'll see atrial flutter with a 2-to-1 block. So you'll have a QRS complex that's transmitted, followed by one that isn't, followed by one that is. And that's where you get this flutter wave from. So this bit here is essentially a bit of a 2-to-1, a 2-to-1 block. This bit here is a 3-to-1 block. So you can see that it's varying, but there is still some regularity to it, in contrast to atrial fibrillation, where it will be completely irregular. Does that make sense? I know it's quite a tricky ECG. But if I bring this one up, which is AF, you can see that there's less of a pattern to it. If you look at the rhythm strip at the bottom, there's no regularity to it really at all. It's completely all over the place. And it's got this this wiggly baseline. You can't really discern any of the P waves. in comparison to the flutter, where it's got this classical sawtooth baseline with the occasional conducted QRS complex. So obviously this one's the AF with the fast ventricular response. This one.
Is it SVT?
It is SVT, yes. SVT is a bit of a funny definition, but it's generally what we would call SVT. The proper definition for this ECG is AV-NRT, atrioventricular nodal reentrant tachycardia, which most people would describe as an SVT, and we would on the wards at work. If we see this ECG, we'd say it's SVT. The actual term SVT essentially just means any tachycardia originating from above the AV node. So you speak to a cardiologist and they will shout at you for calling this SVT, but in general, the majority of us would call this SVT. So this SVT or AV-NRT is where you've got this reentrant pattern actually within the node itself. So you get this little cycle and it just keeps going round and round and round and round, and conducts them all the way down the conductive system. The rate is very, very, very fast with these, or it can be, up to nearly 300 beats per minute. So very quick. It's the most common arrhythmia in everyone. Often if you've had a little bit too much caffeine, you might feel yourself just have a little bit of a palpitation for a few seconds, and then go back to normal. So more than likely that is a small bout of SVT that's self-resolved. If it doesn't resolve, it then requires treatment, and we'll look at the algorithm a little bit later on. AVRT is the other sort of SVT, and this is the one that occurs in those that have got an accessory pathway. So this classically is your bundle of Kent that you get with Wolff-Parkinson-White syndrome. You've got your AV node here, and in the first type of AVRT, the electrical impulse goes down the AV node and then goes back up the reentrant pathway and forms its own little circuit like that. And it can go the opposite way down, so it can go down the accessory pathway and then back up through the node in that way. What you'll note with the Wolff-Parkinson-White syndrome, I think we've got an ECG a little bit later on, that you get this pre-excitation, which you'll have all seen and read about in the textbooks, where you get this sort of scooped, so really short PR interval, where you get this scoop up towards a QRS complex because there's a bit of pre-excitation of the ventricles. So it starts to contract before the proper impulse comes in from the conducting system. If the patient has got Wolff-Parkinson-White syndrome and they go into an AVRT, that feature of pre-excitation is lost on the ECG, so you just won't see it. So it will look like a normal QRS complex, essentially. So it's very, very difficult to distinguish.
Charlotte's just asking, in order to diagnose Wolff-Parkinson-White, if fast, how to diagnose? Do you have to slow down? What could you give?
So yes, you do have to slow it down. You could use a variety of things. So we'll come on to the tachycardia algorithm shortly, and touch on Wolff-Parkinson-White and the nuances with treating the tachyarrhythmias. So hold the question, and I will come to it shortly, because I've got a little slide talking about the Wolff-Parkinson-White syndrome and how to slow it down and things. But very, very good question. This is your orthodromic AVRT tachyarrhythmia. So this is where you'll get a narrow complex tachycardia. When you look at differentiating it between the SVT that we spoke about, the AV-NRT, and this is very, very, very difficult because they look almost the same. The literature will say that you can usually see P waves when you've got AV-RT. So if you look very, very closely at particularly V1, you can see that on the T wave there's a little bit of a notch right at the top. So there is the P wave that they're describing, which is why this is the orthodromic AV-RT. Very, very, very difficult. It would be extremely harsh if they gave you something like that in the exams. And in clinical practice, you generally want someone senior to look at the ECGs anyway. So don't worry yourself too much. It's more of a good to know thing. The SVT, the AV-NRT, is the most important one to know. Again, this is the antidromic AV-RT. So this is where it's going down the accessory pathway and then back up towards the AV node. This literally looks like VT. It's almost undistinguishable from ventricular tachycardia. Thus, it must be treated as a ventricular tachycardia, regardless. So don't go trying to distinguish VT from antidromic AV-RT, because doing that, you will cause harm to the patient because inevitably you'll miss a VT. So just treat it as a VT. For an academic purposes, if in a background of Wolff-Parkinson-White syndrome, potentially this could be AV-RT. This is your Wolff-Parkinson-White syndrome ECG. You can see here you've got this pre-excitation, this really, really short PR interval. It looks a little bit like a triangle. That's the way I've always remembered it. So this is Wolff-Parkinson-White syndrome. Interestingly, Wolff-Parkinson-White syndrome, by definition, you cannot have unless you have had an SV, sort of a tachycardia. If you just have pre-excitation, it's not called Wolff-Parkinson-White syndrome. So if you've not had an arrhythmia, it's not called Wolff-Parkinson-White syndrome. You've got to have the arrhythmia for it to become the syndrome. So we'll touch on the treatment of the Wolff-Parkinson-White shortly. Most of you should be able to diagnose this from this ECG, I would hope. So this is...
Sorry, me and Helena were discussing in the background.
Right.
Charlotte has said VF.
Yeah, VF, absolutely is VF. If you see this, the patient will be in cardiac arrest. This is not associated with a pulse whatsoever. So yeah, this is ventricular fibrillation. So we're not going to go through the ALS algorithm and cardiac arrest in this lecture. That's in the next lecture next week, where we will go through cardiac arrests and advanced life support and things. This one is slightly different. This is your torsades de poids. My French pronunciation was very poor there. You can see, if you look on this bottom strip, you've got this sort of polymorphic big then small complex to the VT. So this is a polymorphic VT associated with long QT. So think about all your electrolyte abnormalities that cause, hypokalemia. There is a risk that can then progress to torsades. Torsades can then progress to ventricular fibrillation or ventricular tachycardia if it's left untreated. Okay, so we've gone through a couple of ECGs. We've gone through quite a few. So if anyone's got any questions about the ECGs themselves, just pop them in the chat and then we'll try and answer them towards the end. In the meantime, we'll go through the bradycardia algorithm and then the tachycardia algorithm as a treatment for the arrhythmias, with some nuanced as well. Okay, so with both of the algorithms, it talks about these adverse features and whether they're present or not. Does anyone know what those adverse features are?
So Rabia said heart failure, ischemia, shock, syncope.
Absolutely perfect. Those are the 4: shock, syncope, myocardial ischemia, and heart failure. So if you've got any of those, they've got adverse features. So this is what the algorithm looks like, obviously assessed with A to E and go through the motions with that. And then you look at whether they've got any of these life-threatening signs. And that will decide on which way down the algorithm you're going to go for the bradycardias. If they do have evidence of these, then the initial treatment we're going to give is atropine, 500 micrograms IV. So you want to give it in a large cannula, followed by a good flush, and see whether they respond. Generally, you want to wait about 30 seconds to a minute to see if they respond to it. And then we can repeat the doses if there isn't a satisfactory response. You can repeat the atropine. Sorry, Caroline, go on.
Sorry, I was just going to ask, as an F1, would you be doing like the atropine yourself, or would you get senior involvement?
So in reality, no is probably the simple answer. If you've got a patient on the ward that goes profoundly bradycardic, that is unstable, you would be probably putting a peri-arrest call out. Identifying it is the most important thing, and getting some senior help. So I would probably say no as the F1. I wouldn't want to be giving atropine on the ward on my own. I would want someone senior there. So I would put a peri-arrest call out and wait for them to arrive, because generally they arrive quite quickly. The other flip side of that answer is if they don't, then yes, you would be expected to give it. But in general, I would put a peri-arrest call out and allow the crash team to sort it out.
And then Charlotte's asking, would you give it all at once?
Yes, you give it all at once, followed by a flush. Just give it as a bolus. It's not an infusion, it's just a little bolus of atropine.
Yep. Thank you.
That's all right. You can repeat the atropine up to a total of 3 milligrams. So you can repeat it, repeat each 500 up to a maximum of 3 milligrams. Sometimes you will see, particularly some of the ICU teams, give things like isoprenaline instead of atropine if the atropine initially doesn't work. I think it's more of a personal choice and experience more than anything, but this is something you definitely wouldn't be expected to do. If these medical managements don't work, you need to look at transcutaneous pacing. I've got a YouTube video showing you how to pace a patient shortly, because it's something that gets spoken about in lectures and things. Oh yeah, you need to transcutaneously pace the patient, but you're never actually taught how to do it. So if you get to a point where you're expected to do it, then it's good to know how. If you don't know how to do it, then please don't do it. Obviously, you do. If you do advanced life support, you cover transcutaneous pacing in detail. So please don't worry about it. What I'm going to show you is more just an academic thing. If you're going down there isn't any life-threatening features, you need to then ask yourself this other question with the bradyarrhythmias, whether there's a recent asystole that they've had, or whether they're in one of these dangerous arrhythmias that we talked about, whether it's the Mobitz 2 AV block, or whether they're in complete heart block, or they've got ventricular pauses. If they are, then you're going down the atropine medical management pacing route, because they're more likely to progress to asystole. Okay, so I've got a little very, very short video to show you. So hopefully you can see the YouTube video, Carolina, is that right?
Yeah, you can.
Perfect. So I'll mute it and I'll just talk you through it myself. So this is similar to the defibrillators you'll see on the wards in the resource areas of A&E and things. You'll see that this patient's got a rate of around 37. When you're looking to transcutaneously pace a patient, one of the first things you need to do is look at this pacer button here. So once you press that pacer button, it will ask you to select what rate you want to pace the patient at. So what rate do you want the patient's heart to be beating at with successful pacing? Generally, they say around 20 to 30 beats above what it is already. So in this one, I think they select 70 beats per minute. The next thing you're going to do, is increase the amplitude of the pacing of how much energy is going through the defibrillation pads. You increase that slowly until you see on the strip that every single pacing pacer has got a QRS complex directly followed by it. So you can see it currently when we're sitting at 35 milliamps. This is a pacing line, and it doesn't have a QRS complex associated to it. So then we need to increase the amplitude of the pacing. So you can see if you take it up to 70 milliamps on this patient, you're then getting capture with every single beat. And then the defibrillator will just pace the patient at that and keep their heart rate at whatever you've set it at. This is obviously a temporary measure, not a permanent measure. So if you're getting towards that point, you need to then think about involving cardiology and doing something like transvenous pacing and going down the pacemaker side of things. Again, something you're not expected to do on your own. If you've done your ALS, then you would be expected to do this. But if you haven't, then obviously not. So that's just a summary of the whole bradycardia algorithm from the Resource Council. It's really important to remember for exams because it's easily examinable and you need to know it. Moving on to the tachycardia algorithm then. Again, looks at these adverse features that we mentioned. If there are adverse features with a tachycardia, the algorithm suggests that we do a synchronized DC shock, which is different to defibrillation and cardiac arrest. And again, I'll show you a very quick video why. The patient could be conscious, so it's really important to remember that if you're going to shock the patient with electricity, you need to give them some sort of sedation or anesthesia because it's painful. So you need to give them some sedation. If these shocks are unsuccessful, you can then try some amiodarone. So you give the amiodarone in 300 milligrams over about 10-20 minutes. You can then repeat the shock. And then you would set up an amiodarone infusion over about 24 hours. So this is if there's adverse features. If there aren't any adverse features and you've just got this tachyarrhythmia, you then go down the algorithm. So we'll look at whether the QRS complex is broad or narrow. If it's broad and irregular, it could be atrial fibrillation with bundle branch block, or it could be this polymorphic VT, sort of the torsades. If it's AF with a bundle branch block, we'll treat as if it's a narrow complex atrial fibrillation, which will come on. If it's this polymorphic VT, we'll give some magnesium sulfate, 2 grams over 10 minutes. It's quite effective in treating torsades, is the magnesium. I'm not 100% sure why, but quite effective. If the QRS complex is broad and regular, that's VT, almost by definition. Even if you, like I say, you've got this, could it be AVRT, could it be VT? Just treat it as VT, because that will help the patient. You don't want to be stood there thinking, oh, is it, isn't it? Just treat it as ventricular tachycardia. You give the amiodarone, 300 milligrams IV over sort of 10 to 20 minutes usually, probably followed up by then an amiodarone infusion. It does mention here if there's SVT with bundle branch block and all of this, treat for a regular narrow complex tachycardia. However, that decision would need to be made by a senior decision maker or a cardiologist. in practice as a sort of junior level resident doctor, I would 100% just treat it as a VT. If you're going down the narrow complex QRS route and it's regular, the first thing to try is vagal maneuvers. Does anyone know what we mean by vagal maneuvers? Or any examples of vagal maneuvers?
Blowing through an empty syringe or pressing on the, so Charlotte's saying Valsalva, so they're pressing on carotids.
Correct. Yeah, you can do a carotid sinus massage, which is a type of vagal stimulation, or the classic one is blowing. You get a big 50 ml syringe that's empty and just ask them to blow as hard through it, which will stimulate the vagus nerve. Seems very strange, but it does work sometimes. If that's ineffective, then we're going to go to the line of giving adenosine. So atropine in bradycardia, adenosine in tachycardias. So this is for your sort of SVTs, if you want to call them that. First dose is 6 milligrams. If that doesn't work, then you give 12, and then if that doesn't work, you give 18. It used to be 6, 12, 12, but they changed it to 6, 12, 18 in the 2021 guidelines. And then if you are going down the irregular route, you're looking at your atrial fibrillation. So rate controlling with your beta blockers. It says consider digoxin or amiodarone if the heart failure, but generally we'd give a beta blocker. Okay, has anyone got any questions about the tachycardia algorithm? What I would say with the tachycardias, it can be slightly nuanced, particularly with the atrial fibrillation. So, for example, if you've got a patient on the ward that isn't known to be normally in atrial fibrillation, if they've got quite a severe chest infection or a urinary tract infection, they may very well tick over into atrial fibrillation for a period of time. That atrial fibrillation is more likely infection driven. So generally, we wouldn't treat the atrial fibrillation straight away. We would try and treat the infection, and then if that treating the infection doesn't resolve the atrial fibrillation, then you would think about treating the actual AF itself with beta blockers and whatnot. Same with sinus tachycardias. If it's sinus rhythm, try and treat the cause first. They might be tachycardic because they're in pain or they're constipated. So it is slightly nuanced in practice, but definitely this one. This is more your sort of SVTs to give the adenosine. Okay, so another very quick link to show you about the cardio version. So you can see here that they're attaching the pads to the patient. They're giving some propofol sedation because the patient's conscious. And then I'll just pause it here. So what you'll see on the defibrillators is you'll see this sync button. If you're doing DC cardioversion for a tachyarrhythmia, i.e. not a cardiac arrest, you need to ensure that the patient is synced. So this means that you can see the little triangles on top of the QRS complex. This means that the defibrillator is identifying each R wave. If you shock the patient not on this R wave, you'll send them into a VF. So you need to make sure that when the defibrillator shocks them, the electrical impulse is given as the R wave is there, if that makes sense. So when you charge it, and then when you press the shock button, you may very well see a delay from when you've pressed it to when the shock is actually given. Just because the defibrillator is waiting for it to identify an R wave that it can shock on. So it's slightly different to cardioversion to defibrillation in cardiac arrest. Okay, so we're coming towards the end. So I just thought I'd touch a little bit on adenosine first. You'd all know that it blocks the AV node. That's the principle of how it works. It causes hyperpolarization and essentially an increased threshold for the action potentials, meaning that there's no action potentials that are conducted through it. The practicalities of giving adenosine. So it comes in little, unhelpfully, it comes in small ampules that you then have to add together. You need to give it through a large bore cannula, so preferably a green cannula, as close to the heart as possible, so probably in the ACF. You give it as a rapid injection, followed by a rapid flush, and you jack the arm up in the air to try and get all of the adenosine to the heart as quick as possible. This is because the half-life of adenosine is around 10 seconds, so you want to make sure that all of it and as much of it gets to the heart as quickly as possible, without delay. So it's a bit of a technique in giving it. Some cautions, contraindications with adenosine. Asthma and COPD, it may worsen or trigger symptoms. Although in practice, it's only for a very short period because the half-life is so small. So it's a bit of a risk benefit on whether you give it or not. Obviously, don't give it an AV block because you're going to make it worse. And then Wolff-Parkinson-White syndrome, just be careful. It's not a contraindication as such. Some clinicians will give it, but just be aware that if you're giving it and the patient does have Wolff-Parkinson-White syndrome, you will stop the you'll block the AV node, but you may very well precipitate the impulse down the accessory pathway, which could potentially precipitate a ventricular tachycardia. So just be very careful. But it can be used in that situation. If you're not doing that with Wolff-Parkinson-White syndrome patients, coming back to the question from earlier, generally you would try and get the patient to have ablation of the accessory pathway as a treatment for that. But some clinicians may very well try the adenosine in the acute phase first to see whether it reverts them back into sinus rhythm. But just be wary that it may very well send them into a VT. Okay, so that concludes everything. So I will leave it there, and I am happy to answer any questions. Find the.
Hi, Cameron. When you give adenosine, do you need to be on continuous cardiac monitoring?
Yes.
Okay.
Yeah.
So would you need to put a crash call out if you were to give?
In practicality, yes, you would.
Okay.
Yeah. All of these, if you're using any of these bradycardia, tachycardia algorithms, I would be putting a peri-arrest call out probably. You want, if you need to cardiovert them, you'll need sedation. So you'll need an anaesthetist there. Adenosine essentially it's chemical cardioversion. You're stopping the heart. So there is a risk that the heart doesn't restart essentially. So you need a crash trolley there. So yeah, I would always put a peri-arrest call out if I'm going to give adenosine. I've just seen the question. So if you can't relatively give adenosine to unmasked Wolff-Parkinson-White, then how would you get them SVT? It's difficult. I've not done it myself or not seen it myself personally, but looking at the literature and things, most people would probably give adenosine if they're unstable and they're poorly with it. Obviously, if they're unstable to a point where they've got adverse features, then you're going to cardiovert them. So if you've got any queries about giving the adenosine, I would probably just sedate them, cardiovert them as the treatment as an acute tachyarrhythmia. But you definitely need some sedation. if you're in A&E, we wouldn't necessarily put a crash call out in A&E, but those are generally managed by the A&E team. But if you're on the wards and you've got patients in SVT or pulsed to VT, then definitely be putting a peri-rest call out. We've got a patient on the ward, on the orthopedic ward at the moment, of all places, that keeps going into SVT. So he gets a peri-rest call around twice a week, usually, to have adenosine, which is great for an orthopedic ward. So he requires adenosine to revert himself back. Okay, has anyone got any more questions?
Just shared on the screen the feedback form, which is very useful for Cameron as well. So please, guys, fill that out, and we'll be able to post this video on YouTube so you can revisit it.
Thanks very much, guys.
Super, that's great. Thank you so much, Cameron. Really, really useful.
No problem at all. We'll see you next week for, I think ALS is the first one next week.
Yeah.
So yeah, we'll go through the ALS algorithm and thing next week.
Perfect.
Okay.
Thank
Well,
you. Bye.
all right, no worries. See you later. Bye. Bye. Bye.
Bye.